Hello friends, welcome you all at Indian Institute of Learning Life Saving Skills. Today we'll be discussing the most important and awaiting topic is chest pain. Most of the time you will be getting the patients of chest pain in emergency department, OPD and clinics, super specialty, multi specialty and even in quaternary care hospitals. So even with the best of investigations and diagnostic tools, we are failed to diagnose sometimes and patient end up into mortality. So we'll be discussing the statistics, how it take place or how we sometimes able to diagnose correctly and sometimes we are failed to diagnose it immediately, late or sometimes never. Yeah. So if we consider the 100 cases of chest pain, 100 patients of chest pain, it could be either male or either female patients. Okay. So next step is, out of 100 only 60 to 70% will get for IPD. This is a large statistics we are considering IPD, or we can say for observation rather than IPD we can use the, so it's a mixed group of population. So either they will get observation in daycare, ICU, etc. So out of 60 to 70%, only 10% of cases would be primarily of ACS, that is acute coronary syndrome. Yes, you have heard rightly, acute coronary syndrome. Then this acute coronary syndrome is of two types. One is high probability ACS and one is low probability ACS. So high probability ACS is the moment patient will come with chest pain, will do the ECG and there are changes. So the changes could be STEMI or it could be non-STEMI. Okay, so these are the ECG changes, high probability acute coronary syndrome. Then low probability acute coronary syndrome is of your unstable angina. When patient reaches to the hospital, ECG comes normal. Okay. Then it's angina pectoris. So this is how we'll evaluate. So patients those who are under category of high probability acute coronary syndrome, immediately you will diagnose ECG, STEMI, non-STEMI. You will refer the patient to cardiologist, or based on your specialty you will manage the case. So either you will plan for CAG, available, not available, or you will plan plus and minus for PCI, percutaneous coronary intervention, or otherwise called as PTCA, percutaneous transluminal coronary angioplasty, or based on if it is still deeper or still involving the many tissues, it will lead to bypass. So this is a very clear-cut presentation. Patient of chest pain of either sex presented, immediately you have classified high probability, low probability. You have done the ECG, found STEMI, non-STEMI, cardiologist, angiography, PCI, PTCA, TVD and bypass. Clear cut, no if and but cases. Directly you can streamline. Even for a fresher healthcare professional, he can evaluate the case. The problem comes when there is a low probability. When there is a low probability of ACS, okay, and ECG comes normal, angina pectoris. So when ECG comes normal, we'll plan for cardiac biomarkers. Cardiac biomarkers, either we'll do for CPK MB, TROP-T, I, then cardio-specific, quantitative or qualitative. So you'll be thinking, yeah, as usual we are doing, so what great in that chart? Yeah, so most important is when we have done the ECG, there is a low probability. So we have done these investigation, these also comes normal. So there are two observation, either plan for CAG, even if it is low probability cases. Second one is patient discharge home, not willing for CAG because the patient heard, patient attendants heard ECG normal, so no need of further getting investigate. Discharging home. The problem is when these 2% of cases which we are missing comes with either in cardiac arrest or they comes with a frank ACS, acute coronary syndrome. So the wisest task is lying here, low probability cases. The wisest task is lying here, the low probability cases when we are dealing. Unstable angina, ECG comes normal because there is a no myocardial necrosis, no myocardial damage. Here is no myocardial damage or no necrosis, so you won't be finding, and there is a no complete obstruction, so that's why you are not finding STEMI, okay, and you are not finding cardiac biomarkers are elevated. So these patient has to be kept in observation. See, there is nothing like that the positive history, patient is father, mother, anyone else, grandmother having this kind of history. If the patient comes with a chest pain of either side, whether it is a right side or left side, or interscapular pain, or interscapular pain, or epigastric discomfort, there is something called as angina equivalents. Angina equivalents. Okay, the pain of angina is equal to. So these patient has to be considered on high priority because we want to reduce this 2 to 5% of mortality. This 2 to 5% of mortality. I'll give you an example. A small brief example I will consider here. A 46-year-old male comes with a chest pain, ECG normal, cardiac biomarkers normal, patient kept for observation, sent home. There are evidence incidents which shows after few hours, or after few days, this patient brought in cardiac arrest of same hospital, ER or ED, or a other hospital to ER or ED or cardiac department. So here lies the importance of that 2 to 5% of cases which are low probability. Say they are nothing to do with the age, as we are observing cardiac arrest more in the young age. So nothing to do with the age, nothing to do with the history that parents is having. So these all are correlation, nothing to do with the typical chest pain. Okay, it could be atypical. All lies here is about the highly suspicion highly suspicious, and low probability ACS, acute coronary syndrome, planning for CAG if at all patient gives consent. Low probability cases planning for CAG, that is coronary angiography, just to reduce the mortality in that 2 to 5% of cases which are usually missed even after the high end of investigations, including ECG, echo, stress echo, Doppler, or TMT. So this is a take-home message from a patient of chest pain. We must be highly suspicious, excluding the age, either sex, history, typical chest pain, atypical chest pain, low probability, high probability, coronary, acute coronary syndromes, just to rule out these 2 to 5% of cases. Sometimes we'll admit the patient and do repeated ECGs and repeated cardiac biomarkers comes normal because patient is at rest. Then repeated cardio biomarkers. So this is how I am briefing once more. 100 patients of chest pain, either sex, 60 to 70% will get hospitalized, and out of that what we are getting, so 60 to 70% of cases IPD or observation day care ICU. Out of that 10% comes out to be ACS, acute coronary syndrome, and this acute coronary syndrome is high probability acute coronary syndrome, STEMI and non-STEMI. So we'll take the opinion of cardiologist, CAG, PCI, plus and minus, PTCA or bypass, as so on. This pathway is very clear from here to here. So now we are suspicious about the atypical chest pain, age, no history of cardiac illness in the family previously, unstable angina, ECG normal. ECG is normal because, and cardiac biomarkers are normal because there is a no complete obstruction, one thing. Second, there is a no myocardial damage till now, no necrosis. So this all comes normal. Then even we have to plan for these cases of CAG, just to reduce the mortality in 10 to 5% of cases. Sometimes these patients, those who are discharged from ED, emergency department, or ER, from observation room directly to the home, they presented with the cardiac arrest or frank ACS due course of time to the same hospital or to the other hospital. So this shows the importance of doing coronary angiography. This shows the importance of doing coronary angiography, that which is the gold standard in either case. We have seen multiple cases, those sometimes discharge home or by communication gap or knowledge gap, so they sent home. ECG normal does not mean patient is normal. ECG normal, if we plan that ECG is normal, so it is nowhere in the concept that heart is normal. ECG is normal, so that is nowhere that heart is normal, coronaries are normal. It is just a preliminary investigation which can done anywhere, small setup, and we are doing in the even tertiary care hospitals. ECG is normal. So the further investigation has to be done based on availability. If patient is not willing for coronary angiography, that is echo, stress echo, then Doppler and TMT, or there is a something called as conventional CT angiography, that is CT angiography, not conventional, CT angiography. But Nowhere it is going to replace us the conventional angiography, which are doing sometimes called as the mini angiography, which is the gold standard to find out, because our target is to reduce the 2 to 5% of cases. Sometimes what happen, I'll give you a live example. A patient comes with a pain abdomen, persisting pain abdomen. Ultrasound obviously comes normal. He has undergone n number of ultrasound all are normal. Sometimes we'll send the patient for mesenteric angiography. Yes, mesenteric angiography after doing the preliminary investigation with the history of the patient.